All right, let's begin. Good afternoon. Can you hear me? I'm not using the microphone because I realized that I ran out of the wipes. So to be safe, I passed each of the two groups the microphones instead. Right. All right. We are now in week 11 of the course. I don't know if you are feeling the heat of it already. We are like two more weeks to go before our last session. So after today, next week we will have no more debates, right? Today's the last debate. And next week, we would have essentially just a lecture and discussion on the finance, the aspect. And thereafter, the following week, that means final week, we'll have your presentations. We have 3 hours for that. You won't take that because the time limit is 6 minutes per group. So we would have some time. So the final week, I would also reserve time for any questions or any of the subtopics or areas that you like a bit more discussion on or some info on. I possibly can afford to spend a bit of time in the final seminar to address this. I can prepare a bit of content if you wish to find out more, just for your knowledge, just for your learning, right? In no way, do I expect that. I mean, and as you know, there's no final exam in this class. So that means none of this will be tested under stressful conditions, right? Exam conditions, which I believe you would appreciate. Um, yeah, that said, I do expect a high level of rigor in your projects, both the digital media production as well as in the individual write-up, right? You have guidelines on that already. I understand that for many of you, though, perhaps not sure if all, for many of you, this may be the first time you're doing some kind of digital media production. Can I just have a show of hands if you don't mind? How many of you, for you, it's the first time you're doing a digital media production for a course in NTU? One. Oh, okay. So other people have done. Okay, thank you very much. So your other instructors have tried to, right? Okay, to get you to do this. Okay, good. Then you're not new to doing this. In my very interestingly, in my other class, I teach in the master's program in the applied gerontology as well, and I think to all of them, it's the first time they do a digital media piece. When I broach the assessment topic. So very interesting, very different experience here. Right. So the last class really will be reserved for each of your presentations. People will obviously be able to ask questions, and you can respond accordingly. And then we will have some time, which so in the weeks prior, in the days prior to that, leading up to that, in the next 2 weeks, therefore, if you have some areas where you would like some more coverage, a bit more coverage, I know in the last 10, 11 weeks, I couldn't cover everything in the textbook, even in those chapters that are relevant, right? So if you want to find out more about this or about that, feel free to write me an email, right? And I see what I could do and whether time permits in the final seminar. So I hope that will be helpful, useful, and interesting to at least a good number of us here. Yeah, that's I think what to expect. And okay, about assessment, um, just to manage your expectations, as I have done in the last two journal entries, I would also grade your final journal entry and then give you your mark. I've given you a numeric mark, right, out of 10. So I'll continue to do that. And those three would be the only marks you know for this course. That means I would not be at liberty to disclose other marking components, right? Well, because I'm not allowed to do that. Yeah. Not that I don't want to do that. Yeah. Some classes you would realize that maybe a bit more, those 100% CA type of classes, the lecturer, the instructor could disclose a bit more. But all of us, as I understand, are not allowed to disclose everything, even in a 100% CA kind of situation. That's just the instruction. Yeah. So I think that's all I have to cover. Any administrative questions you'd like to ask about the course so far? No? Okay. Okay. All right. Okay. All right. Then let me go into the content proper. I will start with about 10 to 15 minutes on the slides, first few slides, and then I hand over to the organizing team of the debate to get the debate going. When the debate is over, which will be an hour plus later, I'll carry on the remaining content. I actually did reserve time to go through one of the psychological therapy as a demonstration here in class. It's not in the slides. It's called mindfulness meditation, which is, if you have read on hypnosis, one way or one you can say entry point to learning clinical hypnosis, right? So you may be interested. You may be interested to know that nowadays there are scripts which one could use to learn hypnosis by self hypnosis, and thereafter you could, in an ethical and also in a skillful manner, once trained, of course, right, use this method or use this procedure not just on yourself or with yourself, but also with some other individual, right, in an ethical fashion, of course, right? So I'll talk more about that later. So I hope you are interested in that. From what I know, how many of you in one of those other classes, once again, has done anything like this in class? Guided imagery, mindfulness meditation? Yes, you have. Thank you. 2, 3, 4, 5. Can you just share with me briefly what you have done? Hypnosis? You did that? Mindfulness meditation? Okay, thank you. You did mindfulness meditation? Okay, thank you. All of you did that. What class is that? Must be the same class. Positive psychology. Okay, excellent. Okay, so there is actually So then those of you who have done that might know some of the uh, what do you call it, literature support for it. The how it works. Really, this whole field called psychoneuroimmunology, right? Psychoneurology or neuropsychology aspect of the treatment. Okay, that means for those of you who are adept, maybe I can do intermediate level. Let's see. I'm not sure. Let's see. But I don't want all of you to fall asleep at the end of the class. And those people who are back home, of course, if they fall asleep, that's fine. But yeah, here. So right. Okay, we'll do some of this later. Hopefully that is interesting to you after the debate. Okay, let's go into the slides proper. People at home, I hope you could hear me clearly. If not, write a comment on the chat. All right, let's go. So that's the outline. We talk about what normal late life sleep is and how that might be different from normal sleep in middle adults, younger adults. We talk about the prevalence of late life disorders, sleep disorders in Singapore and in the US, as stated in the textbook. We talk about etiology or causes of late life insomnia. Some of these causes are similar, some of these are different from just insomnia in general. So some of you may be interested if you realize that you suffer from or you kind of think that your sleep could be improved. And then we'll go into interventions. So there is obviously the biological, the psychological, and then of course from the debate which will discuss and argue about hypnosis, right? The point on hypnosis as well. Okay, so what is late life sleep? Well, it is sleep. How is it similar or different to, sleep in general? We find that in late life sleep that older adults experience less, that means shorter duration of N3 stage, or what we call deep sleep stage, right? And more light sleep, or N1, stages 1 and 2. So that is different. So all else being equal, stage 1, stage 2 will be shorter than younger person. Will be longer than younger person, and then stage 3 will be shorter. Now, this phenomenon occurs more in older men than older women. That's what research found. And we also found that before 60 years of age, one starts to experience these, right? You can say phenomena. I won't say symptom because it's not disorder or disease, but phenomenon. And then by the time you hit 60 or 60 plus, it's more or less stable. So chances are your parents, if they are in that age group, 60 something, then they have a certain sleep pattern. Chances are that it's going to remain unless something unforeseen crops up, which we can discuss later. Older adults also, as compared to younger ones, take a longer time to fall into sleep. They tend to have more what you call interruptions in sleep, and older adults may have more difficulty getting back into sleep or resuming sleep. This phenomenon particularly occurs after 90. That's what research has found. The reasons for these two above phenomena are unclear so far. Research is limited in this area, while sleep research is quite established for, just in general, for, you can say, the whole age group. But taking a life course perspective, it means splitting into young adults, middle adults, older adults, and then within older adults, right? Once again, young, old, middle, old. The older part, we see less research. Less research has been done. So once again, another gap, which if you're interested, I always say this. I hope one of you will become, a researcher in that area one day, become an expert, if you will. You can contribute to human knowledge in that area. So there are hypotheses or guesses about the reasons. First, what we call biopsychosocial reasons. Biologically different. Older adults have some biological differences, have different cognitive mechanisms, right? We know that there is different cognitive impairments or differences in older adults after, say, 55. We learned that in earlier classes. Or there could be social reasons. Older adults face more complex social situation, perhaps, than younger adults. So those could be that model called biopsychosocial model, which is not new to you, I believe, that could be one reason. We don't know whether it's supported or not, remains to be tested. Same thing for the other one here. Perhaps age-related changes in neurobiology, right? So the idea that serotonin levels, growth hormone levels are different in older age than in younger age, right? So is it an interaction between biopsychosocial, or is it more physical, i.e. neuro/biological? Right? We don't really know for sure, because there's some evidence that supports both, you can say, models or hypotheses at the moment, right? Not incredibly strong. So it really remains to be seen. So that's normal late life sleep. Now, we know that anyone, whether older or younger adults, when you go into a clinic and complain of sleep problems, there are usually sort of three main reasons why people complain of sleep problems. One is, doctor, I have a problem falling asleep. That means getting into. That usually is one big reason. Another main reason that people see a doctor or sleep specialist for is, doctor, I kind of keep getting interruptions in sleep. I mean, I keep going to the toilet, but actually I'm not passing urine or motion. I just wake up and think about going to the toilet, and no passing motion, no excrement, and then after that I come back to my bed, I cannot fall asleep. So there are other people who say, look, I have interruptions due to dreams. And the dreams may not always have to be a nightmare or an unpleasant one. Sometimes it could be, somewhat neutral, like just an occurrence of, just some kind of dream, nothing plus or minus about it, but the person wakes up in the midst of the dream. I don't know if that is your experience. And then, so that's interrupted sleep. And then the third reason why people go to a sleep specialist or doctor is that his or her sleep is not of a satisfactory quality. It means, doctor, I woke up as if I haven't slept. I woke up 7 hours later, and it's as if I was awake the whole night. Right. So these are the three main reasons people complain when they see a doctor for sleep. Older adults are no different when they go in to see a doctor. The presenting problem, that means the issue that seems to be most obvious and most uncomfortable to that person, right? Usually is the issue that a person sees a doctor for. However, the reasons that gives rise to these symptoms or phenomena may be quite different in older adults as compared to younger people. Okay, so Bloom and colleagues published a paper, right, that essentially says one or more of the four things there: difficulty initiating, maintaining. Okay, there's this part here. It says waking up too early, somewhat similar, somewhat related to the second of maintaining, right? So once you wake up, you cannot go back to sleep, interrupted, right? And then non-restorative sleep is really about quality of sleep. Wake up as if I haven't slept, not restful, right? And accompanied by daytime functioning impairment. So any of these four seem to be reasons that people would have that says my performance is affected in whatever daytime activity. Say driving, say being in class as a student, say doing work at home, whether it's in front of a computer or not, whether meeting people, just socializing, social interaction, right? And they occur in the context of sufficient opportunity to get the desired amount. So that means that these people, it's not so much the amount, the number of hours or minutes, and it's not so much that the person doesn't have sufficient time or is not willing to put in the time. So we're really talking about, for these four reasons, that people are willing to put in the time, people are motivated to get sleep, get good quality sleep, and most people are, because we kind of feel the adverse effects if you don't have a good sleep, whether you're older or younger adults. So this is what has been found, that if we use DSM 5 now, or the IC, now this is called ICSD, not ICD. So the S is sleep. So International Classification of Sleep Disorders, right? The usual classification manual is called ICD, right? You know that, right? International Classification of Diseases. This is sleep disorders. Both of these diagnostic manuals or classification systems understand insomnia similarly by essentially these four uh, phenomena or symptoms. And we see in the real life, in practice, in my practice in geropsychology, that yes, that more older adults come in than younger adults when it comes to sleep problems. And with now I think with more psychoeducation, older adults begin to understand that they don't want to depend on medications. In the past, we say sleeping pills will do the trick. Just pop a pill, right? I grew up thinking that myself. So sleep problems, pop a pill. No need to think so much. It works, right? We want a panacea, right? We want a quick fix. But now with a better education and health literacy, we know that often that quick fix may work half the time, may not work half the time, but in the longer term, as you would see in the later slides, that they lead to problems. And so now even doctors, right, general practitioners, sleep specialists, as well as psychologists, right, have started to believe and practice this belief that non-medical treatments, non-pharmaceutical or non-pharmacological management should be the first line of treatment. But this is quite different from the last week when we talked about mood disorders. So the pharmaceutical is first line, right? And I even asked you to think about why, reflect on why, and there were good reasons, if you can recall, right? But here we are saying non-pharmaceutical tend to be now understood, recognized as the first line of treatment for sleep issues, both for older adults and younger adults. But in older adults, we find that there are greater complexities. So reasons related to any of these four, right, could be so much more complex, difficult to predict, harder to have one size fit all. So the textbook shows you table 22.1 here, and we could see two things here. One, what is the prevalence across the world? In studies that span China, US, France, Nigeria, and Italy, right, we see the prevalence is anywhere between 9%, 8.9 here, to 44. So that means out of 100, 9 people or 44 people, anywhere between 9 to 44 people, right, in these various countries, right, at any time could be diagnosed with insomnia. And we're talking about older people. So these are, what's the age here? Is I think all above 60. In fact, most above 65. Okay. Now, the other thing we see here is in the red box. for the 60 to 69, 70 to 79, 80 to 89, if we split them into groups, we start to see this phenomenon that there are gender differences. That men tend to, right, report less sleep problems. Therefore, fewer men as compared to women report sleep disorders or sleep problems or get diagnosed with any form of sleep disorders. Right? So women has it harder. Unfortunately, it's kind of unfortunate that, in fact, last week, if you recall, we talked about mood disorders. It's also women, right, who tend to be diagnosed with mood disorders, depression, right? And scientists, neurobiologists, and psychologists, until today, are still trying to figure out why is it so. Why is there a gender difference? Those of you who are interested, you could now revisit that chapter, I think week 2's chapter on menopause and andropause. And you can see that hormonal changes could be one reason. Not, as you recall, not incredibly strong evidence. In fact, in that chapter, I think I said a few times that there are many gaps, right, in the research, right? What constitute menopause, what constitute andropause, what are the symptoms, what are the reasons for those symptoms in each of those categories. But that is sort of possible by psychologists and scientists to be one possible reason. So how about in Singapore? Now, there is this study done and published in 2017. I thought I wouldn't find this information, but I found it. And it seems like we have, 13.7% of older adults reporting at least one sleep problem in Singapore, at least one. Either falling asleep or maintaining sleep or poor quality. Right? Of these people, right, 11 had all three problems. 22 early morning, about 50 getting into, and about 70 interrupted sleep in Singapore, older adults. Okay. So I think I would stop here now. I've just introduced the phenomenon called sleep, normal late life sleep, as well as the prevalence of insomnia in Singapore and elsewhere. Okay. So any questions? Before I hand over to the organizers for the debate? No? Okay. All right. So I think we should go for the debate right now. Okay, so people at home, the quality may be affected, the sound, but you could turn up the sound. All right, so we return to the lecture after the debate.
Hi everybody, welcome to the debate on sleep disorders and intervention. So today's motion is in the treatment of late life sleep disorders. Hypnosis is a medical procedure rather than a psychotherapy. So before we begin, we have three voting polls. So you all can just scan the QR code and the voting results will be displayed on the screen. Okay, seems like everyone has voted. As you can see, like out of 22 people who voted, 55% are on the fence, 32% are on the opposition side, and 40% on the proposition side. So hopefully after the debate, people who are on the fence may take a position. So now I will leave the opening remarks to Shane.
Okay, so in a meta-analysis of cross-sectional studies, the peak of healthy older adults has been observed in more individuals have also been found to have shorter sleep duration Disorders Unit at the Singapore General Hospital reported that about half of people aged 65 years and above do not have a good night's sleep, at least for several times a month. So this is a major cause for concern. Regardless of age, sleeping well is vital for physical health and emotional well-being. For seniors, good sleep remains important as it improves concentration and memory, allows the body to repair cell damage, and recharges the immune system, which in turn helps to fend off diseases. Elderly with sleep problems are reported to be significantly more likely to have a range of chronic health conditions such as cardiovascular diseases, diabetes, and breast cancer. Additionally, older adults who suffer from sleep problems tend to be more fatigued or sleep-inundated, which can in turn lead to an increased rate of accidental injuries and falls. While aging in itself brings about changes in sleep patterns, sleep problems should not be taken as a part of growing old. Proper diagnosis and treatment ought to be carried out to maintain older adults' quality of life. Over the years, a plethora of treatment methods such as cognitive behavioral therapy and bright light therapy have emerged in response to the different types of sleep problems that have emerged. Of interest in the current debate is hypnosis as a form of treatment. Today, the National Institute of Health is supporting clinical trials of complementary and alternative forms of medicine which includes hypnosis. However, whether hypnosis has a role to play in present-day medicine or is better categorized as a form of psychotherapy to treat daytime sleep disorders is up for debate. So the debate here today is similar to past debates we have had in class. The first four members of each team will get 2 minutes to speak. We will ring the bell once when there's 30 seconds remaining and twice when your time is up. After which you'll have 7 minutes for audience participation and 8 minutes for freestyle debate. So throughout the course of the debate, you may pose any questions you have for the teams on the QR code earlier, and please indicate T or O at the beginning of the sentence to let us know which team you're directing the question to. Additionally, please key in your name so that we can identify you if clarification of your question is required. So during the debate, we'll also look out for questions that have been posed by others and vote for them. So once we begin the audience participation, we will not be taking in any additional questions. The top 3 most voted questions will be asked during the Q&A. And should there be time remaining, we will then open it up to the floor or refer back to the slide for the next top voted questions. Finally, we'll move on to the final speakers who have 3 minutes each to close the debate. Then we'll have a short 10-minute break before we convene back again for the concluding remarks and voting. Yeah, so if everyone is clear on the procedure, we will begin the debate. May I invite the first speaker of opposition to the stand? Okay, we are ready. Yeah. Okay, so good afternoon, everyone. Today, the motion set by Wayne that in the treatment of life sleep disorders, hypnosis is a medical procedure rather than a psychotherapy. Before we delve deeper, allow me to help us better understand the two systems. The proposition surrounds our understanding of sleep disorders along the American Psychiatric Association APA's definition that is covers the quality, timing, and amount of sleep that results in daytime distress and impairment in functioning in a person. Also, hypnosis is a state of altered consciousness, usually artificially induced, in which there is a focusing of attention and heightened responsiveness to the cues and commands. A generally accepted understanding of medical procedures is that it encompasses any course of action intended to achieve a result in the delivery of healthcare, while psychotherapy is better understood as a form of talk therapy. Now, to set the tone for today's debate, the proposition would like to specifically mention 3 crucial including criteria in medical procedures that we deem critical in helping us better understand why hypnosis is also a medical procedure rather than a psychotherapy. Medical procedures should be scientifically supported, effective, and used by doctors, and each of these criteria will be further explored by the rest of our team. Our second speaker, Shamira, will highlight the differences between hypnosis and psychotherapy, such as the existence of an altered state of mind that can be backed up by neuroimaging studies. To add on, the APA specifically stated that hypnosis is not a type of psychotherapy, and it is not a treatment in and of itself, but rather a procedure that facilitates other types of therapies and treatments. This will aid in setting the stage for us to consider the points of our first speaker, Amanda. She will build upon the point that hypnosis is a treatment process that is stated by doctors and multiple applications beyond Incognito Therapy, which we are also familiar with. Our fourth speaker, Cindy, will then elaborate on the effectiveness of hypnosis in treating patients with sleep disorders, which will focus on the included criteria to set for medical procedures. All in all, we believe hypnosis is a medical procedure rather than a psychotherapy, and my teammates will elaborate more on the points that mentioned above. Thank you.
So the opposition first speaker, like,
Thank you, proposition. To reiterate, today's debate motion is this House believes that in the treatment of daytime sleep disorders, hypnosis is a medical procedure rather than a psychotherapy. As the opposing team, we disagree with the motion. Discourse define a few key forms of emotion. These are hypnosis, psychotherapy, and medical procedure. According to the APA, hypnosis is a therapeutic technique, i.e., psychotherapy, in which patients make suggestions to individuals who have undergone a procedure typically designed to relax them and focus their minds. In the treatment of late life sleep disorders, it works to change negative thoughts or habits related to sleep so that a person can sleep better once hypnotherapy is complete. On the other hand, the APA also defines psychotherapy or thought therapy as a way to help people with a broad variety of mental illnesses and emotional difficulties. Psychotherapy can help eliminate or control troubling symptoms so a person can function better and can increase well-being and healing. Psychotherapy is also a collaborative treatment based on the relationship between an individual and a psychologist. This also includes changing the cognition of the client, such as in cognitive behavioral therapy for insomnia, CBTI. CBTI is a combination of treatments that includes behavioral therapy interventions, such as sleep restriction and stimulus control, and cognitive interventions, including restructuring dysfunctional beliefs and decatastrofizing negative thoughts about sleep, and sleep hygiene to address factors that may augment treatment outcomes. Lastly, a medical procedure can be defined in two ways. A medical procedure is an activity directed at or performed on an individual with the object of physical health, treating disease or injury, or making a diagnosis. Since diagnosis is an important component of treatment and hypnosis is not limited to diagnostic tools in sleep disorders, it already looks unlikely to be considered a medical procedure. Thank you.
Okay, so I think my issue of what is the obviously what is not regular. First, we often understand the definition of this. We define hypnosis as a state of alternate consciousness involving focused attention and heightened responsiveness to suggestions. In fact, some of the studies have highlighted that hypnosis is a state at which a person's attention is detached from his or her immediate environment. However, psychotherapy does not involve finding being a state of alternate consciousness. Some of the examples of techniques used in psychotherapy involve meditation between the therapist and the client in the form of talking, drama, role play, and storytelling, which got nothing to do with alternate consciousness. This therefore highlights that hypnosis is different from psychotherapy because the key feature of hypnosis, which is the alternate consciousness, is not at all a key feature in psychotherapy. Next, there are numerous neuroimaging studies that have been done to demonstrate the changes that occur during hypnosis. For example, changes in the brain regions can be observed with fMRI and EEG, where there are activations in interfrontal direction, prefrontal direction, MTHFR, neurofrontal cortex, superior frontal cortex, and then anterior and posterior cingulate cortex. Neuroimaging research has also found changes in the brain regions in response to suggestions during hypnosis. For example, recent neuroscience findings showed that when someone imagines something that when someone imagines something as suggestions during hypnosis, be it a color, sound, physical activity, or even pain, similar areas of the brain are activated as when the person is actually experiencing the experience. This highlights that hypnosis is scientifically that unlike psychotherapy, which is usually measured by looking at symptom reduction and remission of disorders, which are not objective measures.
So, but this one you want to
Thank you for this for raising the point of how hypnosis may actually lead to changes in our sensory consciousness. How about the later touching and psychotherapy belongs to the during process? I will discuss this later on. This brings me to my team's first argument that our definition of hypnosis in fact matches the definition of psychotherapy more than just procedure. So according to the APA, hypnosis is quoted as a therapeutic technique. Hypnosis can create a highly relaxed state of inner concentration and focus the attention to a client, and this technique can be tailored to different treatment methods such as CBT. We also want evidence to support that hypnosis as a single treatment modality has been used successfully to alleviate late life sleep disorders like insomnia, rapid methods to manage anxiety and worry, facilitating deep relaxation and controlling mental overactivity and decreasing physiological arousal, which are cardinal symptoms of insomnia. We find that insomnia has been caused and is caused by anxiety, and hypnotherapy is used to help clients as it allows the clinician to gain access to the underlying causes of sleep disorders and help clients manage their intrusive thoughts. This suggests that there can be psychological processes that underlie these sleep disorders, and hypnosis in these situations can aim to address these underlying issues is uncharacteristic of a medical procedure, as it not only targets the physiological aspect of the person's day, but the psychological problems as well. Hypnosis is also heavily influenced by a variety of psychotherapeutic techniques, and clients may even become empowered by learning to hypnotize themselves at home to improve sleep to achieve a deep state of relaxation. If you recall some of the techniques that a psychotherapist may teach, for example, using a blood record and CBT, can also be implemented by the client once he or she experiences improvement, as compared to a medical procedure which is more or less performed by the doctor or practitioner exclusively. The patient hardly conducts a medical procedure on their own, even after seeing improvement in their own experiences. Hence, we find that when considering hypnosis in late life treatment of insomnia, it draws more parallel to psychotherapy as compared to a medical procedure. So hypnosis is not a type of psychotherapy, rather it is a medical procedure where changes in the patient's perceptions, thoughts, feelings, or behavior are suggested. Hypnosis can certainly be used as a tool to amplify the effectiveness of therapy, however, it is not therapy itself. Hypnosis is a specialized technique and is used as an adjunctive intervention within a complete psychological and medical treatment package. Although hypnosis is commonly associated with CBT and the opposition definition in treatment of daylight sleep disorders, it cannot be assumed that they are essentially the same thing. In fact, a meta-analysis study has shown the effectiveness of treating sleep disorders when hypnosis is used as an additional tool on top of CBT compared to the sole use of CBT. The enhanced effect of hypnosis proves its distinctiveness from the main therapy procedure. Hypnosis is extremely versatile and has many different applications in the field of medicine, mental health, and even dentistry, and should not be passed up as just psychotherapy. In the treatment of late life sleep disorders, hypnosis is used as an identification tool in the context of analytical hypnotherapy, where the root cause of the patient's disorder is revealed during the dream state. Just as the doctor makes an initial diagnosis of symptoms before treatment, hypnosis allows identification of the symptom before it is further addressed in psychotherapy. So in this context, hypnosis is an identification tool used to pave the way for therapy. Furthermore, there's been a prevalence of research that sheds new light on how hypnosis is used as a tool in contemporary medicine. So, American Medical Association approved 2-year study by the Council of Mental Health reported the definite and proper uses of hypnosis in medical practice and recommended the establishment of necessary training facilities. This was further supported by the British Medical Association and APA, which stated that physicians would be seeking psychiatrists for training in hypnosis to be used in clinical settings. Clinical research has also shown the use of hypnosis as a tool to aid medical treatments for breast cancer and rheumatic conditions where associated sleep disruptions were significantly reduced. So that this great body of clinical research proves hypnosis is a medical procedure rather than a psychotherapy. Thank you for your ideas. I like to illustrate another reason why hypnosis is more of psychotherapy rather than a medical procedure, and that is hypnosis is relational. The client is inherently involved in changing that situation hand in hand with their hypnotherapist, whereas for a medical procedure, it is done by the medical professional on or to the patient rather than with the patient. Again, we reiterate that a medical procedure is an activity directed at or performed on an individual with the object of improving health, treating disease or injury, or making a diagnosis. On the other hand, during hypnotherapy, clients have to recognize themselves in what the therapist says and how it is said. In receiving confirmation of their experience, they find the boundaries of the self withdrawn, becoming inclusive of both themselves and the therapist. This makes it possible for the therapist's suggestions of hypnotic and hypnotherapeutic experiences to be experienced as insider ideas rather than rejected as outsider impositions. There is a mutuality and synergy in the relationship between hypnotist and client during hypnosis, and that highlights the involvement of both the therapist and the client in order for it to work. In fact, according to Fuller and colleagues, the majority of people reject the idea that a hypnotist is in charge and that people can be hypnotized against their will. Most believe that collaboration is required for hypnosis. As Shaw also admits it, the flesh and blood of hypnosis is its multi-dimensional clinical richness and variation only appears when hypnosis is viewed in terms of the dynamic interrelationships between real people. Similarly, in cognitive behavioral therapy, or CBT, a form of psychotherapy, the psychologist and client work together in a collaborative fashion to develop an understanding of the problem and develop a treatment strategy. Now, does hypnosis in the treatment of late-life sleep disorders not resemble psychotherapy more than a medical procedure?
Thank you.
especially for the treatment of insomnia. In a study done by Becker and colleagues, they reported 50% of patients suffering from chronic insomnia experienced improvement in their sleep pattern lasting over 16 months after a simple 2-second treatment course using hypnosis. And additionally, anxiety and pain is one of the main reasons behind the development of sleep disorders, and hypnosis is thus a powerful tool that has been shown to help ease those symptoms. Studies have shown that hypnosis can be useful for inducing a state of physical relaxation that is at least comfortable, diminishing the sympathetic arousal that's usually associated with anxious preoccupation, usually found in patients suffering from insomnia. Overall, hypnosis appears to be effective in treating sleep disorders across different studies and disorders. In a meta-analysis of studies using hypnosis in adults for sleep problems and other conditions comorbid with sleep problems, 58.3% of the included studies reported hypnosis benefits on sleep outcomes, and 12.5 reported mixed results. It is thus evident that a significant percentage of existing literature supports the idea that hypnosis is effective in treating late-life sleep disorders. Moreover, hypnosis could be more suitable for late-life sleep disorders, as it is a rather unintrusive treatment and thus poses less health risks for older adults who may be increasingly immunocompromised as they age. A meta-analysis of the risks and benefits of hypnotic sedatives in the treatment of insomnia in older adults found that there was an incidence of increased risk of adverse events like falls and cognitive impairment with use of hypnotics. Thus, hypnosis could be a more attractive option for older people.
Thank you. We invite the host speaker for the opportunity. Thank you for your point on the effectiveness type 1 hypnosis in sleep disorder. But in the context of late sleep disorder, we have to recognize that hypnosis like CBTI looks to change cognition towards solving the sleep disorder rather than a directed action that underlies your definition of medical procedure. Hypnosis is not to be confused with administration of hypnotic drugs like sleeping pills that induce state of sleep by affecting the biological system. Administration of hypnotic drugs is a medical procedure, as you have stated, which is an intended action that is directed by a medical professional to help a patient sleep. It's one-way directive action from doctor to patient to achieve an immediate solution of sleeping. Hypnosis, according to Chong in 1985, is an engagement of interpersonal and intrapersonal thought, where hypnotists and individual work together to change negative thoughts through imaginative experiences using suggestions and reflections. Hypnosis may result in alteration of perception first, then possibly subsequent actions or behaviors reflected upon by the individual. So as such, the focus of hypnosis and its main contribution is on the cognitive or psychological aspect, just like cognitive behavioral therapy for insomnia, CBTI, which involve cognitive restructuring to change inaccurate or unhelpful thoughts about sleep. As such, hypnosis could lead to subsequent corrective behaviors towards sleep disorder, but still focus on changing the cognition, which is the main focus of most psychotherapies to address psychological conditions such as depression. It's not a medical procedure that tackles sleep disorders directly like hypnotic drugs, which can immediately help you sleep. Furthermore, psychologists without medical training can receive training and certification to conduct hypnosis. It therefore cannot be a medical procedure that must be done by a licensed medical professional. In sum, given the cognitive focus and interpersonal and intrapersonal thought processes, hypnosis should be labeled as psychotherapy. Hypnosis can change your mind, but cannot necessarily change your sleep.
Okay, so now we'll move on to the audience participation round. So like looking at Slido right now, there isn't any questions you want to pose. You all can scan the QR code. If you all have questions, scan the QR code and also like pose some questions. Meanwhile, the organizing team has a question for both teams to sort of think about. So our question to both teams and whoever wants to answer first, basically is what is the significance of classifying hypnosis either as a medical procedure or psychotherapy? Like what is the significance of that and the implications of it being classified as one or the other? On late life sleep disorders. Yeah.
I think one of the implications that just came to mind immediately as the previous speaker from my position has thought of, he said something along the lines of like, there are people who may not be medical doctors who are doing hypnosis. And I think that is actually the reason why we need to make hypnosis a medical procedure, is precisely because they're not classifying as a medical procedure now, then random therapists or random people on the street can get like a license to do hypnosis. So I view it more as a emergent property of it not being off as a medical procedure than an evidence that it is not a medical procedure.
Thank you for the question. So I just would like to bring up the last biggest point on the practitioners, and actually agree very much on the point that hypnosis is effective in treating daytime insomnia. However, given the meta-analysis, we actually found that because precisely because hypnosis is effective, we need to ensure that the method of classifying under a medical procedure or psychotherapy has important and measurable implications on the general population. So the practical implication that we are going to view now is whether or not people would actually go to these practitioners to accept hypnosis as medical procedure. If you look at the meta-analysis, people are more likely to reject hypnosis as a medical procedure, but they were open to the idea of hypnotherapy. So this is a barrier to the use of hypnosis simply due to its classification under a medical procedure. So given its efficacy, as you brought up just now, we do not want to prevent people suffering from insomnia from receiving the right treatment, like hypnosis, because of the preconceived notions of hypnosis. Therefore, this very practical implication emphasizes the importance of careful wording and classification strategies of hypnosis as a psychotherapy instead of medical procedure.
If not, we'll move on to one question here. So, someone has posed basically, is it possible for hypnosis to involve a medical procedure like psychotherapy? It's directed to the population.
Our team research on the difference in hypnosis in a medical context versus psychotherapy is that when it's used in a medical context, it's most of the time used to explain medical issues or the complexity of symptoms or the causes behind a certain medical issue, as compared to psychotherapy, which can be used in regular psychotherapy or like let's say mental disorders. So we believe that's the
And also, just to realign everyone back to the motion, unfortunately, you can't put a stance based on a motion that is both, because the motion states that it has to be one or the other. That's why we really argue that it can be both. So that's the reason why you don't see it much in arguments.
Okay, so let's move on to the next question. So not directed to population. So by restricting hypnosis to be part only to the licensed medical professional, does it risk decreasing the accessibility to hypnosis as a form of treatment?
I want to also say that hypnosis, right? I think both teams have defined hypnosis as the altered state of consciousness. So, like going back to my point about how we should use hypnosis as a tool and as a medical procedure, right? So, instead of just defining it as psychotherapy, so like and also like the preconceived notions by everyone that okay, like hypnosis must be therapy and therefore it is safe to be used. Yeah, so but if we change our perspective and if we see like hypnosis being used as a tool instead, I think it will unlock it will really maximize the benefit of hypnosis used as a tool in different settings. Yeah, and I think it's also because like there's also like growing research on how hypnosis as a tool is really used in medical procedures. So you realize that actually all this while we have been using hypnosis as a tool for psychotherapy, but like not much research has been done in the clinical setting, right? And that's also because of like everyone's preconceived ideas about hypnosis. Yeah, so actually by restricting it to just psychotherapy, we are kind of like restricting ourselves and not allowing us to unlock the full benefits of hypnosis.
Thank you for your answer. So, looking at Slido, there's additional two more questions, but I would like to open the floor to see if anyone has any questions for the opposition team. Because the questions on Slido are all directed to the proposition team. Yeah. Does anyone have any questions for opposition? No more question for opposition? Okay, then we'll take the next question to opposition. So,
not scientific enough. Because technically psychotherapy is part of the psychology. And as of now, there have been studies that have been trying to say that psychology may not be like scientific enough. So I'm asking if that's your idea or yeah.
I think what we are trying to say is actually the differentiating the outcomes. Yeah, like the outcomes of like the physiological outcomes and the psychological outcomes. Yeah, so not to say that psychology is not scientific because psychology is social science, but we're talking about like the different outcomes that hypnosis produces. So like one study provided evidence that yeah, hypnosis actually changes slow wave sleep. Yeah, increases slow wave sleep in older adults. Yeah, so in this sense, we're not saying that psychology is not scientific, but we're just saying that the outcomes are different. Yeah, that hypnosis, because traditionally we always view that, okay, hypnosis has more biological or physiological outcomes in a sense. Yeah, but there has been evidence that shows that hypnosis can actually help to provide and pave the way for such physiological outcomes that we usually neglect. So I think our focus is on the different types of outcomes, not to say that what field is scientific, what field is not, but really just the different kinds of outcomes, physiological and psychological outcomes.
Okay, so now we'll be moving on to the freestyle debate. So if anyone wants to like start first, you can just go ahead. Just start now.
Just like those things, you know, without it.
Oh, okay. So I just want to clarify that our definition of hypnosis is a therapeutic technique, which is like psychotherapy, where clinicians make suggestions to individuals and undergo procedures designed to redirect their focus of mind. So it's not a state. So in our readings, it will say that it's a state of outer consciousness, but our focus is on the process itself, which is a therapeutic technique. So to clarify, we don't believe that it's an outer consciousness. Therapists have no control over it. It's a work in progress application. That's probably anything to see that.
Yeah, because cannot.
Yes, it's a process slash technique. I guess, sorry, you know, like, oh, sorry. I clarify that it's a process, not a state. So it can be of the consciousness, but it's not a state. Like hypnosis, you cannot reach a state of hypnosis. There's no definition for what is that state. But hypnosis, the procedure itself, the way where there's mutually the process where the suggestions are made and we can choose to take the suggestions or not. Yeah. So it can go into personal or intrapersonal.
I think this, of course, after all, debate about if it is a state simply because that there is like neurological imaging studies that shows that when a person is under hypnosis, there are some different like physiological responses which happen in the brain. So that's why we think there is a distinct of the state to begin with. And actually, given its process, how does it affect the arguments again?
Okay. So my response to you is that since it's a state, how is it a medical procedure? Right? It's not even a procedure, it's just a state. It's that I want to be in it, I will be in it. If it's like a therapy or a procedure, so process, right? It can be a procedure, it can support it. But if you say it's a state, we don't really think
think when we are arguing of hypnosis and the sense of emotion, we are thinking of the medical procedure inducing the desired state of hypnosis that we are talking about. So I think it's a bit of semantics that it affects separating the two of them. I don't think it really affects the argument. But yeah, I dismiss that by a point that it's a state and that you want the medical procedures or the procedures that get you to the state to be considered as medical.
Okay, so I think if you want to bring back the main point, right? Actually, the main argument that we had when we listen to your argument is that your definition itself of what is a medical procedure seems to sound like a psychotherapy, where you say that it's scientifically supported and effective. That's two out of the three inclusion criteria, and isn't psychotherapy scientifically supported and effective?
I think scientifically supported maybe wasn't very well phrased. It's what Amanda said just now. It's more of the how we measure the outcomes. So in terms of hypnosis, the outcomes are a bit more objective in measurement. But for psychotherapy, it's a little bit more subjective. So you can talk about well-being, increased well-being or increased anxiety. All these things are still subjective, and we have to do a scale for them. So we believe that that's where the distinction between psychotherapy and hypnosis lies. It's the end state and it's the end goal that we are measuring. Just try as
Okay, yes. Hypnosis as an experience, what you mentioned, it leads to valuable outcomes in like health and sleep, right? Psychotherapy, okay, this might go a little bit off tangent, but similar reasoning. When it comes to say the medical disorder of anxiety, it's also a health condition. Psychotherapy would then lead to better weight outcomes that solve this medical issue of the anorexic condition, which is gain weight and get high BMI, which is also a visual outcome, getting a better night's sleep. So yeah.
Maybe you all like to use these last 2 minutes to, bring it home. Okay. So, since it's a medical procedure, how do you prescribe hypnosis as an altered state to a patient to improve sleep? Since it's a state, how do you prescribe that?
As you say, I don't think that we should semantically separate the two procedure and the state. I think that ultimately, of course, we only have to prescribe the procedure, just as like you prescribe a surgery, you don't prescribe a soft broken foot, you prescribe surgery, but hopefully you want to get a state of the angle, which is the state of hypnosis.
So it's a topic to how can we get there to hypnosis, right? Which is our definition, where you need to do the therapeutic technique when clinical patients need to make suggestions to individual and need to undergo this procedure, which is psychotherapy, because we try to relax the mind, focus the mind, and try to change the thoughts. Sorry, no.
Was that a question?
No. Okay, there are no further questions. Then we'll just conclude this time. And so we will begin with the opposition team, final speaker, and thank you.
Thank you, organizing team. So this is what the proposition team has tried to convince you of. That first,
not, and that in the immediate hypnosis of hypnosis is not a psychotherapy, and it's used as a component in treatment. Secondly, the proposition has tried to state that hypnotherapy is changes negative thoughts or habits. We help people change their negative thoughts or habits to sleep better, and there's a therapeutic relationship with the physician. Their explanation of the altered consciousness of hypnosis means that it is not a psychotherapy as you are not being in a state of precisely of altered consciousness. Lastly, that hypnosis itself produces effective results due to the significant percentage of literature showing that it is effective in resolving late life disorders. However, my team, your physician, still firmly believes that hypnosis procedures sound precisely like psychotherapy, and is the process of hypnosis that is therapeutic in nature. Hypnosis procedures, on the contrary, do not sound like a medical procedure, because work is done in a medical procedure. Work is done on the patient instead of in hypnosis where work is done with the client. Thirdly, hypnosis changes the cognition of the client, which strongly mirrors the work completed during psychotherapeutic techniques such as in cognitive behavioral therapy. In fact, we use cognitive behavioral therapy in insomnia to help clients be able to sleep better. And lastly, we also raised the point that there's a practical implication of how hypnosis is a psychotherapy due to the reduced barriers to people who suffer from sleep disorders from receiving treatment, as they feel that when it's considered a form of therapy, that you're more inclined to use it than when it's considered a medical procedure. Lastly, we also tried to raise the proposition that the definitions for psychotherapy, that the definitions for medical procedure are actually sound precisely like psychotherapy, where two out of three of their inclusion criteria state that it's scientific and effective, which is just like a psychotherapy. Lastly, the fact that we call users of hypnosis clients suggests that they are precisely not doing medical procedure that would require them to call patients. Thank you.
So may I write that down for conversation?
Thank you so much. I think that where this debate will be won and lost is precisely the definition of medical procedure, which most of us have been arguing about against. And the reason why we believe that medical procedure should be defined more broadly now is because it's 2021 and we have to change how we feel about medical procedures. Typically, like for example, one of the definitions that we want is that it must be a doctor doing to a patient, and it must not have a collaboration, like involvement within the therapy for it to be considered a medical procedure. Then my question is why not? Why must it not be a collaborative? Why must it be a doctor doing a patient only? And I think along the lines of psychotherapy, you're saying that like 2 out of 3 of our inclusion criteria can be fulfilled by psychotherapy. The reason why is psychotherapy is not still a medical procedure because it's one of the 3 are not included, and you have to understand that all 3 inclusion criteria are just as important as the other. So I don't think it's a very good argument to say that just because 2 out of 3 is in it, that it has to be considered a medical procedure. At the end of the day, if one of them is not, then it's not a medical procedure at all. And I think that's important to think about. And I know most of the people who are listening right now might be thinking that like this debate is like debating whether a metaphor is a metaphor, but it's a bit hard to think about it that way. So deny that hypnosis has certain elements that make it seem like it falls under psychotherapy, just as the opposition has pointed out. And this is just like all the metaphors as elements that make it seem like it could be a bird. However, you have to decide if this is a medical procedure that just so happens a small amount of elements of psychotherapy or vice versa. I think that's where I think our opposition actually believes that it's a medical procedure with small elements of psychotherapy. Our group believes that the factors that make hypnosis a medical procedure are more salient and representative of hypnosis as a whole. And we laid out 3 inclusion criteria for medical procedures that it should be scientifically supported, effective, and used by doctors. Our second speaker, Shabira, actually mentioned about how there are some key differences between hypnosis and psychotherapy, such as the evidence of neuroimaging studies. This also fulfills one of the inclusion criteria we have established, which is like scientific feedback. knowing that there's a difference between them, I think two speakers just went on to justify why we believe it's a medical procedure. And emphasize that hypnosis is a tool. It can be used by other processes other than therapy, such as analysis. He also went on to establish the effectiveness of hypnosis as a medical tool in treating sleep disorders, further fulfilling the last inclusion criteria, effectiveness. Thus, we believe that for late-night sleep disorders, hypnosis is a medical procedure rather than psychotherapy. Thank you.
Okay, thank you both teams for that lovely debate. So right now we'll be going on to our 10 minutes interval break. Okay, so Valerie will be doing the concluding remarks. She will summarize the whole entire debate. So Valerie.
Well, firstly, it would be helpful to show a summary of the historical limitations that both groups have recognized because they're quite different. So, firstly, for hypnosis, it is an altered state of consciousness. Opposition states that it was a therapeutic technique and it was between people. And for psychotherapy, opposition states that it's a form of therapy, whilst opposition states that the most similar is that it's to help people with mental illness and specialize. For clinical procedures, opposition states that it uses any course of action intended to achieve a result in healthcare. While opposition stated that it's an activity directed for an individual to improve health and treat diseases, injuries, or to make a diagnosis. So moving on to the summary of the different points. So for opposition, they stated that hypnosis meets the three crucial inclusion criteria, which is scientifically supported, number two, effective, and number three, based by doctors. And secondly, they also stated that hypnosis is not a psychotherapy as it uses an altered state of consciousness. And thirdly, they also stated that hypnosis is a tool to facilitate medical procedures. They also use solution therapy, which is very different from psychotherapy. And lastly, they also stated that the effectiveness of hypnosis in medical treatment shows that it's a medical process because of the evidence shown. So now moving on to opposition. So they stated that the definition of hypnosis mentions one of psychotherapy, which is therapeutic technique. And secondly, they also stated that it's not a medical procedure because it is a relational one between two people. So it requires both of them to agree and to form a therapeutic alliance before effects will take place. And thirdly, it states that they stated that hypnosis is the process of changing one's cognition, which is not seen in medical procedures. And lastly, also that medical training and certification is not required for hypnotherapy. So moving on to some recommendations. Sorry for the long slide, but firstly for proposition, we were wondering, like other forms of psychotherapy could potentially lead to physiological outcomes. So for example, like EEG, fMRI could also show that psychotherapy could also lead to some differences in imaging. So how they can we differentiate, like based on outcomes, how they can we differentiate what's psychotherapy and what's medical treatment? And for opposition, we also thought like because because a lot of the debate was arguing based on the definition that hypnosis is a state of altered consciousness. So in medical procedures such as pharmacotherapy could also lead to an altered state of consciousness. So that could also be said about hypnosis. So as such, it would also be argued that some forms of medical procedures may also lead to altered states of consciousness. So it's not really limited to psychotherapy. Okay, so moving on to overall recommendations, we thought that both teams could explore how the concept of hypnosis could differ across culture, so like the Eastern culture, Western culture, and in terms of how this could influence the classification of hypnosis as a medical treatment or as a psychotherapy. And secondly, also both teams could have better address the concept of late life because most of the arguments are based on generally whether or not it's a medical procedure or psychotherapy. So we could have looked into specifically at late life sleep disorders versus like other issues.
Okay, so now we will be doing the post-debate voting. So your can go and cast the vote.
Okay, thank you. Thank you to the organizing team. Both mics are requires to be charged. Just a moment. Okay, you can hear me, right? Okay. So, was there a change? It looks like no change, or is it the other way around in the voting pattern? No change, right? What was the pre-vote? They were on the fence. Yeah, I recall that. Then now we seem to have nobody or few on the because I don't see on the fence. Is it zero? Okay. Okay. So it's about 1/3, 2/3, right? Post. So the pre minus the on the fence is also about 1/3, 2/3, right? I think 14% I saw, and the other one I forgot how many. Is it correct? Okay. All right. Thank you very much. So we have a small number, we have a large number who kind of decided after the debate from on the fence to either P or O. And then the proportion kind of remained before and after. Very interesting. Last week we had quite a different phenomenon, right? Last week we had the opposite effect after the, from 1/3, 2/3 this way to 1/3, 2/3 the other way. So really, to me, at least from the learning point of view, from a learner's point of view, if I would just sit there as an audience, and I have been in the 5 debates, yeah, I realized that even my own understanding uh, could be changed by the, 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 the persuasiveness, the structure, the sequence of presentation. Yeah. And so far, I'm quite happy that we didn't get so agitated in the debate. We all took this as a learning opportunity. We were very cordial, very civil, and I think all of us seem to be quite happy to keep that as it is. So I'm happy about that. Could could you show the slides, the final slides? I think you had 3. The first of the 2. Yeah. Is there one slide before this? Yeah. Oh, sorry. Okay, not this one. The next one. All right, this one. Okay. Just want to talk about this one. Yeah, on this point. Medical procedures such as pharmacotherapy would lead to an altered state of consciousness. Yes, that's actually factually right. So you know from HP 1000 that there are various ways that one could enter an altered state of consciousness. I think you know that already. So you could enter that in a biological fashion, neurological fashion, behavioral, cognitive, even affective, and nowadays we like to say psychodynamic as well, psychoanalysis. Okay, can I see the next slide? Okay. Both teams could have explored how the concept of hypnosis may differ across cultures. Yes, I agree in that because we know that clinical hypnosis, especially when it comes to improving sleep or altering sleep problems, is very, very subjective. It's very, very peculiar to the likes and dislikes and nuances and idiosyncrasies, eccentricness of the patient slash client slash consumer, whoever the person is. So we know that part of hypnosis, well, part of hypnosis is language mediated. Yes? I mean, if you don't have language, right, whether English or some other language understood by the client, could you do hypnosis? No, right? No, right? Those of you who have done your reading, the 2 debating teams, have you come across any form of hypnosis that's not language mediated? I haven't. Right? So it is language mediated. Because other forms of psychotherapy are also language mediated, yes, one could say, therefore, it is a psychotherapy. So this is one point I'd like to raise. Because language is necessarily cultural, therefore, your point makes sense here. The point by the organizing team that the concept of hypnosis may differ across culture due to the use, right, the difference in the uses of the languages, the various nuances involved in language. Right? You can easily think about, say, any 1 or 2 words that mean something, but if you just translate it literally, it doesn't mean the same thing, right? Across languages. So that's what it means. And how that could have influenced the classification of hypnosis as a medical treatment or psychotherapy. Yeah. Okay. So traditionally, I think proposition and opposition both rightly accepted this, that um, medical treatment tended to be understood as performed by medical professionals. That means doctors, surgeons, right? Surgery, right? Proposition did, I appreciate the creativity there when it says, look, now we're in the 21st century. Yeah. So does medicine really have to be fully practiced by medical professionals? So if I were to be on the opposition, I might say, look, what are the ethics of not practicing medicine as a medical profession? Doesn't medicine or doesn't medical treatment require ethics? Right? Doesn't training assumes one is trained in the ethical performance of, right? So that is something that I could bring. Move on. Both teams could have better addressed the concept of late life in the motion. Yes, I agree. Right. I think we have heard from both sides, or at least I have heard from both sides, and credit to both sides in the debate that you did a fair bit of reading on your own, and yes, indeed, as I said in the earlier part of the lecture, not much research has been done right in late life sleep. So I imagine you find challenge, difficulty in surfacing literature, journal articles, or right credible information pertaining specifically to late life right? Sleep disorders. So I understand why that is the case. I.e., how the classification of hypnosis as either a medical procedure or psychotherapy change when we look specifically at late life disorders versus sleep disorders in other age groups. Now, I should make this a point here. When we say that late life sleep disorders are more complex than right earlier life sleep disorders, is because there are a variety of um, cognitions, behaviors, sleep hygiene problems, chronic conditions, chronic physical health or chronic mental health conditions that an older adult could bring into the clinic compared to a younger adult. If I were to be very sort of crude about it, right? Just a very simple comparison. The variety of issues is more complex, is greater in scope. I don't know about the depth, it really varies from individual to individual, but at least greater in scope. So we would find that whether you're a medical professional or psychologist or just somebody trained to deal with sleep problems, that one always find that medical professionals, these sleep professionals always find that we are inadequately, I would say, equipped, because there's always something else that I haven't come across. That is often the case in sleep, as compared in late life sleep than in, say, earlier life sleep. That's just a general trend I observe, even in private consultancy / practice. Yeah. Although the diagnosis criteria by the ICSD or by the DSM, right, is quite straightforward, right? Yeah, it's quite straightforward. I'll give you an example. There's one client I saw who obviously had interruptions in sleep, like wake up 3 or 4 times in the night. And we are talking about 2 a.m. to 5 or 6 a.m. And who at the beginning was very troubled because he believed, now this is a 69-year-old at that point, believed that he's not getting enough sleep in terms of duration. But after we do psychoeducation on the necessity of some predetermined duration, he found that it's okay to sleep for that number of hours rather than that earlier, longer number of hours when he first came into the clinic. With that thought, with an acceptance or an embracing of that thought, somehow his insomnia is gone. Now, going by criteria, diagnostic criteria, I could write a recommendation to say this person is suspected of having insomnia, at least. But if it's not a problem to him already, is there insomnia? Right? So you could then argue that, look, you can learn to live with the problem. Sure. Now that's precisely what insomnia is about, right? The the degree of which one could live day-to-day life with that contemporaneous or that current state slash quality of sleep, quantity slash quality of sleep that one is experiencing at that point. So unfortunately, diagnostic criteria would not be able to take that into account because that is subjective, right? So that's just something I like to share with you to say, look, yeah, one could really understand, and embrace sleep very differently. And diagnosis criteria may not be relevant to people in their older age. Though we could diagnose if you want to, because once you diagnose, you get treatment, whether it's pharmaceutical, pharmacological, or psychological, and so on. All right, that's the last slide, right? Any? Okay. Um, let me see if I have another points. Okay, in the final thing I would say showdown. That means the freestyle debate. Sorry, no. The fifth speaker. I observed this opposition brought up the process, whether you do the therapy, i.e., hypnosis, with or to. Yes, right. That makes a difference to whether it's a medical or psychotherapy. Proposition, in closing, reminded us of the definition of a medical procedure. You had three criteria or three definition. I took down two. It must be scientifically proven, backed, and then used by doctors. What is the other one? Effective? Was that the second one? Is effectiveness. Okay, sure. And good point, valid. Any medical procedure should pass those tests. In fact, I would say that any psychological procedure should pass those tests too. Of course, opposition won't have a chance to rebut because that wasn't your time. So this is something for us to think about. Is in terms of rigor, I think somebody asked that question in the audience. Has psychology or has psychotherapy become so, so you could say, popular, right? That one does not ascribe a rigor to it. Second, does it even work? Right? Does it even work? So we know that hypnosis works in the literature. It's just that until today, we do not know whether it works more because of the neurobiological changes or because of the cognitive behavioral changes. If it's the first one, then it will be more a medical procedure. If it's the second one, then it will be more a psychotherapy. And we know today, and both sides of the people on both sides of the argument agree that doctors as well as psychologists could use hypnosis. Now, in the earlier days, hypnosis was called something else. It's called hypnotism. And because it was called hypnotism, people didn't like it because associated it with mental intrusion and mind control of another individual, unethical, perhaps even damaging and harmful. Therefore, it, not much development until the more recent years. Yeah. So that's what I would say about hypnosis. So today we have various terms: hypnosis, hypnotic, uh, hypnosis, clinical hypnosis, medical hypnosis. Um, in fact, we could even say, look, that some of those procedures you read about or come across, such as mindfulness meditation, guided imagery, autogenic training, even deep breathing exercises, right, could be classified under this psychoneurological therapy. And each of these could arguably, or in a debated fashion, be some form of self-practiced or self-induced hypnosis. So the textbook didn't cover hypnosis, but as you know, at least these two teams who have researched, it is a credible, scientifically backed procedure for not just late life sleep disorders, but sleep disorders in general. Now, why do we want to bring up hypnosis in late life? There's at least one reason that everybody agrees in the profession, and that is it is because of the complexity of the cases. It is often quite not, unfeasible to have the client come back to help to work with you, to work with the clinician, whether psychologist or doctor, if he or she doesn't see near-term success or almost close to immediate success, even though the measure may be of a different extent. So if I have sleep problems, 20 years of sleep problem, I come in, and after I see the clinician for once and twice, and I don't feel any improvement, I'm not going to come back again. That's what it means, right? So often we see that even doctors, when recommending medical pharmacological treatment, those who are trained, even those who are sort of semi-trained, not fully trained, they quickly try to introduce some form of hypnosis, whether by demonstrating, or by asking the patient or client to do some reading or on his own, right? Right at the first session or second session. It's one of those techniques that we don't know how, but it seems to bring quite a fair bit of short-term or near-term subjective experience of success. Whether one will experience longer-term benefits, right? Depends, right? Okay, I think I should leave you with that. So older people, yeah, I should bring it back to older people. Older people tend to, if you recall in the first lecture, right, tend to not want to sort of tend to put greater weight on quality of life, right, than on other possible issues. Older people, as you have read also, who are in a certain stage of life, tend to value things. I mean, tend to spend their time and resources on things that are valuable, and try not to sort of waste time and explore A and B and C and many other things. Yes, recall that in the first lecture. So with a technique like hypnosis, we can improve not just sleep, but many other conditions that we have read, such as pain, chronic backache, chronic fatigue, irritable bowel syndrome. In fact, a spectrum of what we call stress-related physical problems, spectrum of behavioral issues, and of course, psychiatric disorders such as mood and anxiety disorders. We find that older adults tend to want to come back. Then if we prescribe, say, just certain hypnotic, i.e. sleeping pill for sleep, and this something else for depression, and this something else for, so the older adult, unfortunately, have lots of medications. If you have seen how hospital discharges older people in Singapore and elsewhere, you will find that the discharge takes time primarily because of the medications. It's just a lot of different medication with somewhat different ways and doses that need to be administered. And often the caregiver or family member spend time sitting there or standing there with the pharmacist and trying to understand that. That takes a chunk of the discharge time from hospital to home. Okay, so I should return to the lecture. Any questions on the use of hypnosis? Okay, let me go back to. Okay, thank you very much. Can you give a round of applause to all the debating teams and organizers? All right, let me go back to the lecture. All right. So actually, when I showed this, I didn't realize that the organizing team also will show this. So I will not go further. The next slide. the causes. So essentially in the literature have the three groups of predisposing, precipitating, and perpetuating factors, right? These may be situations and context and so on. Right? Predisposing factors are such as personality, person with type A personality, for instance, may be predisposed to having sleep problems. Hyperarousal of the central nervous system, impaired plasticity, neuroplasticity, right? So the neurons responsible for relaxation are not firing away as much as they should, are not being regenerated as quickly as they should be. Personal history, now that really varies from, that really varies. Some situation may happen, some person may already have physical conditions or mental conditions and so on. It may be medical, it may be psychiatric, or it may be social, right? Okay, so all these are predisposing conditions. Essentially, if you ask me, I would say almost anything could be predisposing. It looks like it. We'll look at the Singapore data later. Precipitating factors, really, just any stressful event. Any event that is perceived by the person as stressful. Perpetuating is what you call aggravating factors. So you already have a sleep problem, it makes it worse. So non-sleep promoting our environment and sleep hygiene change aims to deal with that, right? Like having a clock in the room, for instance. Unrealistic expectation of the sleep experience, which is related to the case I brought up just now, right? Some people would have a certain number as a required or quantity, feeling which he or she is just not satisfied and reports a sleep problem, whereas others may be diagnosable with, using criteria from DSM or ICSD, but nevertheless finds no problem. Okay, so this really is the major theory there. It's called the hyperarousal theory or hyperarousal framework or hyperarousal hypothesis. Right? The idea is that some emotional arousal occurs due to any of these, okay? And when this emotional arousal gives rise to some central nervous system arousal, this central nervous system arousal, right, leads to a complaint of insomnia, of a sleep problem. So what is linked to emotional arousal will be any of these psychiatric conditions, any stressful events, or just in fact the fear of sleeplessness. So this is very self-perpetuating here. When you enter the bedroom, you think about, oh no, I cannot have enough sleep. The next 7 hours are going to be stressful, right? I'm going to be so tired after the 7 hours, more tired than had I not entered the bedroom. Right, that is that. That makes a person feel sad, anxious, angry, disappointed. Yeah, all these feelings are what we call emotional arousal. So these feelings, as you know, could lead to one or more central nervous system, right, changes, such as right here. Um, Sorry, these any of these could lead to central nervous system changes, but each of these on the right side could also directly affect the central nervous system, right? So a vulnerability or predisposition, right, could lead to CNS arousal. Menopause, I talked about this earlier, that could change the way the CNS operates. Stimulants, right? Drinking coffee within 2 hours, smoking within 2 hours, excessive alcohol use within 2 hours, other substances within 2 hours, other medications that may affect CNS due to, say, chronic illness, right? Or injury. Right? All these could change the CNS directly. So you have emotional arousal that change CNS. You also have all these various factors that change CNS. And then these everything in combination, right, are known to be risk factors for insomnia. So it's essentially what we call a 24-hour psychobiological disorder, according to the hyperarousal hypothesis. And so two main parts, and evidence supports hypothesis in younger adults. However, we don't have enough evidence for older adults. So this is where the the new direction or the next direction of research would be, right? To try to replicate this. That means try to investigate one or more of these with older adults. But it's challenging to even get them into the sleep clinic, to get them to sign and say, look, I give informed consent to participate in the research, and then to follow them up for a certain number of months or even years. As you know, sleep problems, right, may need to be observed over a certain duration. And then what if they die in between, right? Right, risk factors, okay, so we have covered that. So summarize all the risk factors. Acute stressor, circadian rhythm issue. It may be a disorder or it could be some form of lifestyle like shift work. So it affects your circadian rhythm, your so-called sleep cycle. Could be a medical condition, medications, substances, or in fact, okay, this term called hypnotic dependence insomnia, it's the idea that sleep disorder occurs when one gets dependent on some substance that is meant to treat sleep problems. So that's what we call the side effects of substances. It could help you relax, right, for that night. However, then psychologically you depend on it, and then when you're without it, you can't sleep. Then it takes a life of its own, such that um, even if even if that person is prescribed that particular dose that he or she used to take, it's not enough. He needs to take more. So we see some kind of an addictive or addiction going on already, where you need more to sort of achieve a certain effect, more dosage, higher dosage of a certain medication or drug, right? So that is, in the case of insomnia, it's called hypnotic dependent insomnia. Next, a psychiatric disorder. Yep, as we know, right? Depression, anxiety disorders, right? One of those symptoms is just affected sleep, right? Poor sleep quality. Unfortunately, fortunately, there are antidepressants which also help one to sleep. So kind of work both ways for sleep and for depression. But thing is, as you will know in the next slide, that there are many of these medications, including antidepressants like SSRIs, right, do affect one's sleep, such that when in extreme, a person may experience hypnotic dependent insomnia, which is not what clinician wants, which is one of the reasons why clinicians now regard psychotherapy, particularly hypnotherapy or hypnosis, as one of the first line of treatment, especially in late life sleep disorders. Finally, SES. So now this is written in a textbook, socioeconomic status, right? Words like poor social support, no friends, no family, right? Person older adult has his or her daughter or son moved away and married, right? Unhealthy lifestyle, potato couch potato in the US, with a lot of that, obesity increasing all over the world, financial problems, so worry related to that, anxiety related to financial issues, right? All these are thought to have some relationship with or some association with sleep problems. The thing is, research hasn't shown us how the mechanism. So I put a question mark there. So yes, we know poorer people associate, poverty or income level, right, is negatively associated with sleep disorders. That means higher income, lower incidences of sleep problem, right? We know that in the literature. But how? How is it? What is the link there? So you have A and B related, inversely related, but right? So research hasn't yet been able to tell us the mechanism. All right, this is okay. This is from the WISE, the Singapore study. We see various conditions, chronic conditions, depression, heart problems, all these physical conditions there, as well as pain, right? Directly related or directly proportional to incidences of sleep problems. The inverse relationship would be physical activity. So more physical activity, less sleep problems. So you see the odds ratio is less than 1. Over here, 0.5. Anything that is where OR or odds ratio is greater than 1 is direct relationship. It means increase in one, increase in sleep problems. Right? So that's what's found in Singapore. Okay, interventions. Pharmacological So we have already talked about hypnotics. These are the three types of hypnotics. We used to call these sleeping pills or sleep drugs, layman term. Those side effects associated with these hypnotics may be quite unbearing, unpleasant to the seniors. So they may complain of slowness in performing logical or math tasks, right? In Singapore and in, I think, Hong Kong and China, older people like to play mahjong, that game. I don't know how to describe that otherwise. So a person under the influence of hypnotics may find that he or she doesn't just perform that well, doesn't do mental calculations quickly enough or do pattern matching quickly enough. Then there is daytime sleepiness, which may be okay but may not be acceptable to some people in older life. Increased risk of falls. This is an issue for older people, peculiar to older people as compared to younger people. Already, older people may be frailer, right? May experience one or more other conditions that predispose them to a higher risk of falling down, such as stroke. Hypnotics may increase this risk. So clinicians now are slower to prescribe hypnotics because of this. One of the reasons. Parasomnia-like symptoms like sleepwalking, right? That's something that unfortunately happens in younger children, adolescent. We kind of think that might be normal. Many of us have experienced one or more episodes of sleepwalking in our earlier days, right? However, older adults, right, who sleepwalk may endanger themselves more than younger adults, and in fact, even adolescents. So this is yet another issue that is peculiar to older adults, of which clinicians tend to shy away from pharmacological treatments. And then, so now the understanding is we could go by pharmacological for short-term use. For longer-term management, we really need to turn to psychotherapy for sleep disorders. All right. So psychological or psychotherapy often is multifaceted. The gold standard, as rightly pointed out by the debating teams, like CBTI, is found in the textbook as well. Last week, we talked about how cognitive and behavioral methods may help somebody with mood disorders, right? Depression, specifically, by changing some negative or maladaptive cognitions or thoughts. Here, we are interested in sleep-related cognitions. Okay, as you will see in the next table, in research has shown that older adults with insomnia have actually shown improvement when they undergo CBTI. If this CBTI if CBTI is done properly, that means the various facets were performed, and of course, if these older adults willingly participate. Right? We know if you have taken other courses in psychotherapy, clinical psychology, you would know that participation, motivation, therapeutic alliance, all these are factors affecting success of psychotherapy, any forms of psychotherapy, right? I think one of the teams, if I'm not wrong, was the opposition, who brought up that relationship is important in hypnotherapy. That's true, right? As with other psychotherapies, but particularly in hypnotherapy or hypnosis, right? Because one tends to be more susceptible or amenable to suggestion when one has a strong relationship with the clinician. That's what research has found. So it's now psychotherapy in general now is now understood to be first line, whereas it is not first line when it comes to mood disorders. Okay, so this is what is found in your textbook. Sleep hygiene really is about the environment and things that you can kind of do before you go into sleep. So there are various checklists available to assess one's sleep hygiene. And 5 of the main things are there. Right? Do you use caffeine? Do you drink coffee before certain time? Before within 2 hours, do you drink alcohol, tobacco? Do you eat something? Do you eat too heavily? How much do you eat? How many bowls of rice or noodles or whatever? Right? Do you exercise? Right, before bedtime. So the advice usually is don't do any of those before bedtime within 2 hours, right? But it's not as if you do any of these, your sleep is going to be affected. So a judicious use of even sleep hygiene assessment is required, because one could quite quickly, when answering these questions posed by the clinician, right, self-diagnose and say, oh no, I have sleep problem, when he or she doesn't have. Right? As you know, any of these psychological disorders tend to have people self-diagnose quite quickly, quite easily, and form beliefs and attitudes about his or her own condition prior to any discussion with the clinician. So, judicious use of sleep hygiene assessments is preferred. Then we talk about stimulus control. What is stimulus? We're talking about the environmental stimulus: light, sound, presence of another person. Right. So lie down to go to sleep only when you're sleepy. Right. Do you use the bed for anything else? So if the bed is not only used for sleep, but used for play, used for, and today we often lie on the bed to use our phone, right? Watch a movie, or do a chat, or watch something on the phone. Now, so those are you can say stimulating activity. So your mind is stimulated, it's aroused or hyper aroused, and then look, you switch off the phone, put it aside, and you hope you can go to sleep. How feasible is that? Right? So if in fact sometimes sex could be uh, could be a hindrance if the bed is used for sex, and sex isn't uh, a, um, isn't satisfactory in the couple's life, in that person's life, right? If in fact there is sexual anxiety, that means if I look at the bed and say, look, oh no, I have to perform. My partner, my wife, or my husband will expect me to, right, to perform, and I don't. I feel stressed. I feel guilty, right, having such thoughts. And then that actually may affect one's sleep, right? Couple that with menopause/andropause at older age. You can imagine how an older person, when approaching the bed, physical bed, thinking about how he or she perhaps couldn't perform sexually as well as he or she used to, right? May have anxiety even just about sleep, i.e., fear of sleep, fear of just having, uh, yeah, just having anxiety when approaching the bed. So, okay, if you cannot fall asleep within 10 minutes, get up, go to another room, only return to the bed if you feel or when you feel sleepy. And that's one of those advice we give. To return, set your alarm and get up at the same time every day, in spite of whether you feel sleepy or not. So having a routine helps your body, and try not to nap during the day, right? Because that disrupts your circadian rhythm, your daily 24-hour cycle. Recall our 24-hour neurobiologic, right, model, right? Okay. Now, the CBT, the C and the B part really are here. The C is the cognitive therapy. Okay. um, Identify maladaptive beliefs. And this is something, in fact, today, right, much as we used to think that CBT is performed with a therapist, with a psychologist, counselor, today, with psychoeducation, with greater health literacy, one could actually do some of this cognitive therapy on his own or her own. Just like one could be trained to perform hypnosis on his own or her own, right? Well, of course, this may require higher level training, more intensive training. What exactly is maladaptive thoughts? How do you identify that? How do you separate thoughts from feelings, for example, right? How do you write a thought or say a thought for what it is without saying things like I feel like X and Y and Z. I feel like I want to go to bed and think that is a thought, right? So identifying maladaptive beliefs, thoughts, replace them with more adaptive ones. Integrate basic education about sleep. Normative sleep patterns, experiences can be helpful in addressing mistaken beliefs about sleep. So one of those mistaken beliefs, very well known, is just I need certain number of hours to have good sleep. Right? That has shown itself to be one of the top, can say, myths or mistaken belief that one has. Right? Of course, there is cause to be concerned if the person tells you every day I only get 2 hours, and that's okay. Every day I sleep 12 hours, and that's okay, right? Because then you would want to check whether the person steady functioning is really okay. All the various things he or she engages in the day, right? And then check his level of activity. Maybe the person actually is depressed. So 2 hours is okay because other than the 2 hours, the rest of the day I just spend, in my room on the bed. Then I will check for depression. Right? Remember sick ECAPs, right? Yeah. So clinicians are trained to quite quickly do, switch from one assessment to another and back to one, right? So that's the beauty of having a clinician do this, a trained clinician, right? It's not as if a layperson cannot be trained. One could and get a certification, right? As rightly pointed out by the proposition just now. Okay, relaxation. Well, part of psychoneuroimmunology, psychoneurotherapy, or hypnosis, it's actually relaxation. The activation of the parasympathetic nervous system, if you recall what that is, right, is one of the main goals of clinical hypnosis. In fact, in medical hypnosis or surgical hypnosis, where one gets a surgery done on a finger, on an arm, right, with zero anesthesia, but under the guidance, under the influence of a therapist, a hypnotherapist, right? One of the active ingredients that worked to so-called prevent the experience of pain is really relaxation. So hypnosis helps one achieve a state of relaxation, which one could then say is an altered state of consciousness, or another person could say we are just more relaxed, so much more deeply relaxed that you don't experience pain. Not less pain, but no pain. Right? As magical or as wonderful as it sounds, it requires you to go through the procedure to appreciate the experience for what it is. So there are various ways one could learn to perform relaxation. So once again, you could learn that in class, you could learn that in a workshop. Nowadays, there are workshops on just 45 minutes, just teach you how to do PMR, progressive muscle relaxation. 45 minutes to teach you how to do mindfulness meditation. 45 minutes to teach you how to do, say, diaphragmatic breathing. Right? These are all the known ways, right, that one could learn and do it himself. Sleep restriction and sleep compression, okay, aims to match the patient's time spent in bed to their actual time spent sleeping. So the idea is if you're on the bed, sleep. Use the bed for sleep rather than use the bed for all the other things. So by learning, and if you recall that, it's called classical conditioning. Bed equals sleep. So then the body and the mind get used to bed equals sleep. So when the moment you see your bed, sleepy. Which is so it is perfectly natural and normal that if you do your work in your bedroom that you feel sleepy. Actually, that is healthy. Well, it is not perhaps satisfying in terms of performance, whatever work you are doing or homework or anything. So but it is by and large, if you are in your bedroom and you feel sleepy, that's normal. It is healthy. Right. So that is one way of doing what we call sleep compression. Prescribed bed, right? A bed can be prescribed. Yes. So the clinician could write bed. That's it. Yep, bed. Prescribe bed and wake times that more closely reflect time spent asleep. So once again, compress all the unnecessary things, move them away, put them to one side first. Just use the bed for the bed. For the bed's worth. Right? That's the idea here. Sleep restriction abruptly tailors the time in bed to reflect sleep needs. Sleep compression gradually reduces time spent in bed to match sleep time. So this is just the technical difference between restriction and compression. Okay. All right. Hypnosis. Many points are raised in the debate, and I'm satisfied that both sides did your homework and did your reading up. Medical versus psychological. Both schools of thought continue to be there. No side is winning the other. It really depends on whether or not scientifically we can uncover the active ingredient of hypnotherapy or hypnosis. Right? Is that active ingredient neurobiological in nature? That means some neurons, some neurological system changes under hypnotic state, or is that cognitive behavior? That means cognitions or behaviors cognitions and learning differs when one is in an altered state, right? So we don't have strong evidence on one side as compared to the other, especially in late life sleep. So that remains debatable. Used by doctors and psychologists and laymen, right? So in my opinion, it doesn't matter. Uh, it doesn't matter as long as it works. If I'm a patient, right? Clinicians, however, especially clinicians, however, tend to be cautious and say, look, we should practice hypnosis on top of all the other therapies that we have learned as a clinician. So a doctor, a medical doctor, will say, look, I'm treating you with hypnosis on top of what I would treat you anyway without hypnosis. So pharmacological. A psychologist would say, I treat you with hypnosis on top of what I would do with you anyway, like CBT. Right? So if clinicians have this kind of system, principle of doing clinical work, then we can say that to the clinician, it is an adjunctive form of treatment. Adjunct, right? To add on, right? However, today, there are clinicians who, in fact, try to use, see if they could use hypnosis first, then talk about either pharmacological or other forms of psychotherapy like CBT. So in the, say, 45-minute consultation that a counselor have, he or she could spend 20 minutes doing an assessment on the sleep hygiene, assessment on cognition, and so on and so forth, all the other presenting problems or issues, and then quickly spend the next, say, 15 minutes introducing hypnosis, self-guided imagery, mindfulness meditation, and so on. And then perhaps in the last 10 minutes, right, say that there are also other treatments, right? But that's because hypnosis slash mindfulness meditation, guided imagery, has the benefit of getting the person to experience something different right there and then. Right? So those of you who have undergone or practiced mindfulness meditation on your own, you probably would experience things like greater relaxation, more regulated breathing, lower heart rate, lower skin conductance. I mean, if you hook your body up to biofeedback monitor, right, lower body temperature, and so on and so forth, drier lips, right? These are all the various phenomena. In fact, I don't know if you heard of this. For mindfulness meditation, um, has anyone of you heard of the shortest amount of time one should do or mindfulness meditation in order to achieve benefits? What is the shortest amount of time? Anybody heard of this or read this somewhere? How long should one take? So I don't have all the time in the world. Mindfulness, imagine this, imagine that, or in this deep blue sea, and then in a dreamlike state that I don't have all the time to do this, doctor. How much? What is the smallest amount of time I need to invest in? Okay, make a guess. Anybody? What do you think is the shortest amount of time one could spend in doing mindfulness meditation / hypnosis and achieve measurable results? How long do you think is required? Yes. 10 minutes. Thank you. Reasonable guess. So I believe 10 minutes, you have done it yourself at least 10 minutes, and then you experienced some result. Okay. Anybody experience result in shorter than 10? Yeah? Those of you who have done it? No? Nobody? The answer is 17 seconds. So Harvard Benson, the Mind Body Institute at Harvard Medical School, okay, I will show the slide later, right? Essentially did a piece of research where they put monks, Buddhist monks, right, hooked them up onto those biofeedback monitors. Of course, these Buddhist monks are well practiced, right? They know what they can do Buddhist meditation, right? Assume some kind of position and do some repetitive chanting, right, and so on and so forth. Religious ones, right? And essentially, these scientists, researchers wanted to find out, right, the before and after, the pre and post. So before the monk starts the meditation, right, the researcher measures and find what you call the baseline or the base rate, body temperature, heart rate, um, skin conductance, and so on and so forth, all those things. Thereafter, right, get the monk to start, and then time, and then watch those indicators drop, right? You expect them to drop, right? Whatever hyper arousal, all this drop. So the well-practiced monks, almost all of them, right, drop quite quickly. No surprise there, but the shortest duration there was 17 seconds. Now, you say that one argument is that, look, these are well-practiced monks. So you have to be a monk, you have to be Buddhist to do that, right? Is that true, right? What turns out is that then they replicated this experiment, RCT, if you like, right, on other people, right? And they found that, look, the active ingredient isn't Buddhism or religion. So there are different people of different religions. But the active ingredient is just well practiced. That means you have practiced it. You've done it many times. You know how to do it by yourself. You don't need someone to guide you. Right? You can achieve it very fast. So they did manage to replicate. I'm not sure if they did manage to replicate exactly 17 seconds, but we know there is statistically significant and clinical significant result. Right. So that's amazing, right? We think we need 5 minutes, 10 minutes, but so it is something worth learning, even for healthy people. What else should I say? Okay, I think that's about it. Okay, so for older people, right? When I start a workshop, I always like to start with these two questions in any sleep workshop for older people at least. So I give them a list to choose from, what problems they experience. So sleep, financial stress, work stress, all those risk factors, right? That I just let them make a tick there. And so this is the result from one of my workshops. Not many participants there. I think I had 10 or 12 people only in that workshop. So essentially the work stress. Right. Then I asked them, have you ever experienced the following situation? Right? Insomnia, feelings of anxiety, loss of appetite. So, or none of the above. So I asked them this, and then I kind of try to see how many people have insomnia. I also see if I could say, look, the mindfulness meditation or hypnosis I will teach you could also help you in anxiety and help you in loss of appetite. In fact, can help you in various other chronic issues as well, irritable bowel syndrome, hip fractures, pain, and so on, right? Chronic fatigue. Okay. So I tell them, look, mindfulness exercise is not some position. It's not something that you need to, what do you call that? It is not something that you need to do, actually, more than you need to think to begin with, right? So you don't have to assume a position. You don't have to know some script like do this, do that. You don't have to say some word or make some sound, right? In fact, any action that you do on a day-to-day basis, such as this, standing on one leg or balancing on one leg, could be a mindfulness exercise. So this is something that I use to say, look, actually all of us could try it, right? So how are we doing with time? Okay, good. Why don't all of us try it right now in class, if you can, if you have no injury, right, on your leg, on your knee especially, right? Before you stand up, right, have a look at the slide first. Okay, I'd like you to pay attention to when you stand on one leg, right, the contraction of your muscles, whether it's your shin, your thigh, or some part of the lower body, and also the contact of your feet on the ground. Just pay attention to that. And if you try to balance yourself, hold on to the chair if you need to. If you don't need to, you can let go, right? And then let's see what the experience is. So if you can join me, I will try to do that myself as well, standing on one leg. So can we have you to stand up if you want to try this together? So we're trying to do mindfulness exercise, mindfulness meditation by exposing ourselves to just standing on one leg. So do some stretching. You have set for the last half an hour, right? Make sure you're in a comfortable posture and position. Wriggle your toes, stand around. Make sure you can hear my voice. I believe you can. Those of you at home, right, feel free to do this. It's completely safe, no side effects, and free of charge as well, right? Except don't do this when you're driving. Okay. Okay. All right. Nobody have injuries, right? Okay. Excellent. So when you're ready, decide which leg first, because after that you don't want to change leg. So decide which leg you want to use to balance, right? Have some safety thing in front of you so you can hold on to if you need to. So when you're ready, right, I invite you to, right, gently lift the other leg up with your good leg balanced, seeing your weight. So I'll do it on my left. Okay. All right. Now focus on balancing yourself. If you lose balance, by all means, get your balance back and focus on balancing yourself. Okay. Focus on the contact between your foot and the ground, mediated by the surface of your shoe within and on the exterior. That's right. Experience the muscle contraction around your thigh and your shin. Right? Focus on how that feels like. If you have any other worry or thought, try to temporarily put that aside and refocus on balancing. Shift your body weight if you need to, just so that you could balance even better on that leg. Once again, focusing on just balancing, right? Now, if you can, while still being balanced on that one leg, right, take one or two deep breaths while staying balanced to help yourself balance even better, because you know a more relaxed person could balance even better. See if you find any other thoughts you could have, and if you do, put them aside for just a few moments and refocus on just your balancing and your breath. That's right. That one leg is doing a great job balancing the entire weight of your body. If you like me, almost falling down, grab hold of something, try to balance yourself again. All right, well done. All right, at the count of three, we'll put the other leg down. One, two, three. Thank you. Have a seat. Okay. All right, I like a show of hands. While you're doing that balancing act on one foot, how many of you, how many of you were so focused on balancing, you weren't thinking or feeling any other things? Hands up. Okay, I see a few. How many of you had other thoughts? Like, when is Wayne going to end? Like, how long would I stand on this for? Oh, I'm hungry. Anyone? Just hands up. It's okay. It's normal to have these thoughts, right? I see about 2/3 of you. Thank you. Now, can I ask you to share? Those of you who have these other thoughts, how were you able to still balance yourself? Did these other thoughts, distract you from balancing, or didn't? So you shake your head. No. Other people? Did these thoughts distract you from balancing? No. Okay, so you're actually quite good with balancing. Maybe next time I should ask you to balance with both. Okay, no, you can't. All right. So, okay, the next question I have asked you: how many of you were able to? How many of you feel the stretch or the, uh, maybe I won't say pain unless you're injured, but the tension on your muscle? Hands up on that good leg. All of you did, right? Thank you. Was that tension unbearable? Anybody? Like, wow, I'm so heavy. I need to finish this. Wayne, hurry up. Anybody like that? No? Okay. All right. Okay, excellent. I think I should increase the difficulty in this class. So I did this. Many of my workshops I do this with middle-aged people, caregivers of older people, and then with those healthy, no hip fracture older people as well. And well, as you can tell, the older one is, the frailer one is, the more challenging this task is, right? So you are all young adults, so I should have increased the difficulty, but I want to make sure this is safe because this is NTU after all. Um, the idea is this, that when you are focused on the tension there, right, you are actually being present. And what I say, being present with the experience of balancing. When you're focused on one thought, i.e., this is muscle aching, or this is quite a stretch, right? You're actually focused on one thought and almost to the exclusion of other thoughts. Of course, if you are physically fit, then could still do this and do many other things. Scratch your head, play on this, watch YouTube or everything, and you could do that, right? But if you are able to focus on one, then the idea is that you are actually beginning to do mindfulness. It's actually a mindfulness practice. So the breathing there and the thoughts and emotion is getting you to be present in that moment. Mindfulness has to do with being present in some moment, right? And just focusing on that particular moment's experience. That's what it is. In fact, then if we go by extension, hypnosis or hypnotherapy builds on that. Builds on that. Two active ingredients are therefore a single-minded focus and a distracted attitude. So I believe many of us are able to have this, at least the second one, because, well, while this is somewhat uncomfortable, you essentially don't make too much of a big deal out of this standing on one leg, right? Now, if you have an injury and this painful, well, this is not a distracted attitude. You want to get it. You want to stop doing this as soon as possible, right? Now, that is not distracted. That's a very focused attitude. I want to stop it. Stopping it makes me feel less painful, more pleasant, more comfortable. A distracted attitude means what? It means nothing. Well, standing on one leg or not standing on one leg means nothing to me. Not inherently meaningful, not inherently good or bad or happy or sad or anything like that, acceptable or non-acceptable. It's just standing on one leg. So that's mindfulness, part of it. So two main ingredients: focus on one thought or one object, and then but the thought doesn't come with an attitude. That's essentially the two main ingredients. Yep, the source there, Benson Henry Mind Body Institute. Now that's the found in Harvard Medical School. That's the area. That's the place where I said that research was done. Right, Benson Henry Mind Body Institute. So that's what mindfulness works. These are the two main ingredients. So things like having a quiet environment, taking a certain position, repeating or chanting a certain word, or making some sound, all these will help only if it helps a person achieve one or both of those ingredients. They are not active ingredients or necessary ingredients on their own. So then from there, right, we could progress to various forms. And one of those things when I have time to run a workshop, what everyone could do, and it helps not just for older adult sleep problems, but in fact, just any forms of discomfort or pain or fatigue in one's body. Right, so I try to get people to pair up, and often it's just the caregiver and the older adult. And then we have a script, get a person to read the script slowly in a well-regulated tone, not with excitement or depression, but just in a monotone, right? To help the person scan his body, because when we scan our body, right, we kind of focus on that certain part of the body. That's about it. And then the meditator or the person doing it, right, will follow the suggestion of the person, right? Now, this is a form, this body scan is just one of the many scripts that you could find on the internet. Right? I can make this available too. We can tailor this script to our own needs, our own body, right, to achieve the results or outcomes that we want. A guided, a well-trained clinician could easily make up his script, right, tailor the script, right, for the benefit of that person, knowing that person or the client or the patient's needs or discomforts or pains, right? So perhaps we should end with this. I like to do a demonstration, and you can follow me do this, right? So no need to do pair work, but I will sit here and let me get myself into, right? And I invite you to join me, put yourself in some relaxed condition and see how that experience is. We are going sort of to a next stage of mindfulness meditation that is a bit more, I would say, advanced. So this one specifically targeted to people with some discomfort, some pain, some fatigue, some part of the body that you are not happy about, or you want change. So if today you woke up feeling loose bowels or headache or Yeah, any biological, right, discomfort, right? This has shown itself to work. I'd like you to experience how it works, and then after we finish, right, perhaps one or two brave souls could share with us what worked or what didn't. And of course, they may be barriers, and we can discuss them. Okay. So, of course, this is optional. You don't have to do this if you are not comfortable for any reason. Uh, right. But if you do this with me, right, can I invite you to sit comfortably right now where you are? Right. Try not to have any disturbances like handphone vibration or phone ring. So you can put that aside, turn it to silent mode. Better still switch it off. I make sure my phone is not with me. Yep, it's not with me. Um, and then just sit comfortably, lean back or shift a position a little so you're even more comfortable to begin, right? So those of you who have something on your lap, like a bag, I suggest you put it down or side because it might drop and it might kind of, you know, unnecessarily alert you or something if you can. But the point is to help you to feel at ease before you even begin. Okay, so so that yep. Okay, all right. So take a few deep breaths. Inhale, and exhale, and inhale, exhale, inhale, and exhale. Right, putting aside other thoughts and focusing on your breathing again. Inhale and exhale, and inhale and exhale. Inhale and exhale. Okay. Right. If you have other thoughts, temporarily put that away and focus on your breathing once again. Inhale and exhale. That's right. Inhale. If you like to close your eyes, feel free to, if it makes you more relaxed. But if it doesn't, it's fine. Right? I will close my eyes, and if you would like to, feel free to close or not close your eyes to feel even more relaxed as you just focus on your breathing. Inhale and exhale. Inhale and exhale. Few moments, I'd like you to join me to just focus on how the tip of your head feels without using your hands to touch it. Just focusing your thought on the tip of your head. That's right. The tip of your head. Enjoying the sensation between that part of the head and the air above it. Picturing in your own mind how that part of the body, of the scalp, is in contact with the air above it and that is at ease. That's right. Focusing now on the tip of your head. I'd like you to now slowly focus your mind downwards to your forehead, just focusing there, even for a few moments, experiencing the contact of your forehead with the air column in front of it, and in fact, just even inside your forehead, how it feels. You may feel a bit of discomfort or pain, and that is okay because you can return to that thought. You could put that thought aside and refocus, just checking your forehead. Now moving downwards to your eyebrows and your eyes, and the part behind your eyes, just focusing on how that feels, even right now. Good. And shifting your body posture if you need to feel even more relaxed as you refocus behind your eyes. Now moving downwards to check your face, your cheek, your nose, and your mouth. And if you start to feel some saliva, it's okay to take a sip or two while still checking and scanning your body. Moving down now to your neck, yes, and your shoulders, both the left and right, and feeling the weight on your shoulders just for a bit. And if you feel any discomfort, once again, you could temporarily take note and put that aside and refocus on your shoulder as you move downwards and focus on your chest downwards to the middle of your torso, slowly downwards to your stomach, checking for any discomfort and sensation, experiencing perhaps the expansion and contraction of the diaphragm as you breathe in and out, and in and out, which makes you feel even more relaxed. As you now scan downwards to your buttocks, experiencing how it feels in contact with the chair you sit on, and if necessarily, changing your posture a bit just to feel even more comfortable as you check your body. Now moving downwards from the buttocks to the hips, to the thighs, both the left and the right, both the front and the back of the thigh, noticing where it is and shifting your focus downwards even more to your knees, both left and right, and shifting yourself to feel even more comfortable as you check your shin, your calves, just that sensation there, whether or not it is in contact with your clothing or with the air above it or around it, feeling even more relaxed, knowing that you are in a state of relaxation that you have created for yourself, completely natural. Checking your body now, even more going downwards from your shin and calf to your heels, left and right, moving forwards a little to your foot, left and right, focusing on the feet, taking note of any discomfort and returning to check your feet, focusing now all the way forwards to the toes, to the tip of each of the toes, starting with the big toe on the left, the second, and the third, which is in contact with your shoes or socks or slippers, and then the fourth and the fifth on your left. And then to your right leg, the big toe, how it feels to be there where it is, to the second, to the third, to the fourth, and the fifth, and keeping your mind focused on your toes. Just for this moment, focusing on how your feet feels, putting aside other thoughts and worries and burdens, knowing that you could come back to them again while refocusing on your toes and your feet. That's right. Very good. You may begin to notice that you're breathing regularly now and still in charge of the process and experience which you have created for yourself, totally free of charge and without side effects. Just focusing on your feet. A few moments, I encourage you to join me to now scan your body from bottom up this time. From the tip of the toe to the soles of both feet, to the heels on both the left and the right, focusing on how that feels now, knowing that you are even more relaxed. Moving upwards from the heels to the back of your legs, the calves, experiencing the muscle tension there, if any, just focusing on that moment and moving upwards to your knees, left and right, focusing on just how it is connecting your shin with your thigh. As you move upwards to focus on your thighs, front and the back, experiencing the relaxation and moving upwards now to your buttocks, left and right, which is in contact with your clothing and your chair. Just that sensation that you've created for yourself, completely deep relax. Feel the energy coming back to you now as you scan from your buttocks to your hips upwards. Now, perhaps arriving at your stomach again, checking if there's any discomfort there. And if you have, you could come back to that again as you scan the rest of your diaphragm area, noticing it rise and fall with every breath. In and out, in and out, experiencing the energy coming back as you check upwards to the middle of your torso, to your chest area, and behind your chest and your back, all the way up to your shoulders, feeling the energy come back to you. You notice your chest rise and fall with each breath. Scanning upwards to your shoulders, to your neck, to now your chin of your face, experiencing that natural, relaxed, deep sensation. As you scan your body upwards more to your mouth, both sides of your face, to your nose, ears, upwards more to your eyes, enjoying that pleasant moment for just a bit more before we come back, knowing that you could recreate this anywhere, anytime, completely safe, no side effects. Scanning more now from your eyes to your forehead, all the way up to the tip of your head, knowing now that you're almost ready to come back, rejuvenized, more relaxed, and yet in charge of this process that you could recreate once again, anytime, free of charge, for the benefit of your body, while still being focused on the tip of your head. Feel the energy returning, and at the count of three, I invite you to open your eyes and come back. 3, knowing it's relaxed. 2, having the energy almost coming back, restored. 1, almost ready to go and be in charge. And now, opening your eyes, coming back to this room, while still retaining the relaxation that you have created for yourself inside. Welcome back. Welcome back. Okay. Okay. Everybody is back. Did we lose anybody? No. Okay. Excellent. All right. Okay. Right. You may, how many of you, do you start to feel kind of teary eye a little? Okay. A few. Um, you feel more relaxed now than before? Now, how many of you kind of fell asleep or almost fell asleep? Anybody? Oh, 2 or 3 or 4. Thank you. Right, 5, 6. Right. And do any of you recognize any discomfort in any part of the body as you scan downwards and upwards? Anybody? No? You did? Okay, 2 or 3. Okay, a few more. Right. I'm not sure about you, but I wouldn't have noticed some of this discomfort in my body if I hadn't done this. Like I just noticed I was feeling a bit itchy on the back. For no reason. And I was quite tempted to put my hand behind. I don't know if you experienced that, to touch the uncomfortable part, but I realized that would spoil my experience, and then I refrained from doing it. And then thereafter, it's gone. And I focused on resuming the scan. Right. Right. Some of you may feel some dryness on your lips. You may need to clear your throat if you want to speak like I am. And it is a different state, right? Maybe we take a minute, like each of us, to just share with the people in your group, in your table, how the experience was like. Just take a minute to do that before we finish. Okay, thank you. Maybe I have one person from each table to just share any common experiences, if any, among the 4 or 5 of you in that table. Right? Anybody? Yes, this table first. Celine and yep. Feel like sleeping now? So sleepy. Common experience. Thank you. Yes, Valerie or yep. Yeah, that table. Any common experiences? Lukman, yep. Sleepy. Yeah, more or less each of you felt sleepy. All right. How about this side? Trisha and Tingyi and Alistair. All quite sleepy. Were you sleepy to begin with just now? Like, both? I see. Chronic fatigue. Okay. I see. So that experience made you feel even more fatigue. Okay. Thank you. And how about this table in the middle? Rachel and yeah. Any common experiences among you, Ling Xian? Yeah. Some of you fell asleep. Oh, okay. They were sleepy. You fell asleep. Okay. All right. Any other common? Okay. On. Thinking something else. Hard to concentrate on the body. Thank you. I have a question for everybody on that point. How many of you heard my voice and my instruction throughout? Okay. Okay, thank you. How many of you actually realized my voice was drifting to somewhere and didn't matter anymore? Like, okay, those who fell asleep and those sleepy ones, I suppose, right? Yeah, that is a common experience that after one gets into a certain state, trance-like state, it doesn't matter what the therapists say. You're in that state, and that the voice there, whatever words, language mediated, we know hypnosis is, but it kind of just makes you continue to be in that state or deeper. And you don't really need to follow right, the voice or the instruction or suggestion very specifically. Yeah. Thank you for sharing. And this are any common experiences? So sleepy and relaxed. How many of you, anyone fell asleep actually, like literally? Okay. Okay, for those of you who fell asleep, not picking on you, but anyone who fell asleep, how many minutes do you think you fell asleep? Yeah, those of you who actually did, if you don't mind sharing. I'll tell you how long we took just now. I mean, just a guess, based on gut feel. Yeah, Rachel. 10 minutes? Or 1 minute? Thank you. And anyone else? Very, yeah, yeah. I see. You were in Right, right. You are in REM sleep now. Then okay, right. And yeah, yeah. That is a very good testimony to the power or the yeah, the potential of suggestion. Yes. Thank you for sharing. And five, so about half of the experience. Yeah, I mean later on I could check the recording, but we took about I think 7 minutes or something. And those of you who fell asleep feel that you were asleep in more than half the entire duration. So imagine if you're well rehearsed, and I can make this script available, feel that you can get into that state quite quickly. You don't need 5 or 7. In fact, 5 or 7, it's the amount of time that you are in a deep state, but you could get into that in a matter of seconds or maybe a few minutes. That is the power it has. Now, of course, you may not want to undergo surgery without anesthesia and just have all these, right? But you can now experience it, right, for yourself, even within these four walls. And okay, by the way, before I end, how many of you during that experience heard the sound of the aircon and the humming? You all did? You did? Right? Quite a number don't, right? Okay, thank you. So you find that, yeah, I heard it, but after a while, it was gone. I don't know if that's your experience. So even the person doing it, so I had to keep myself a bit more aroused than you guys. But I'm conducting the class, so I had this nagging thought, I should say, that Wayne, don't fall asleep because you're conducting the class. But you can imagine if I keep doing this to myself and really thinking and believing and hearing my own voice, what I say, I could get into the state myself, right? Right. So I had this thought, right? This distraction, Wayne, don't fall asleep. So I just being honest, right? So in a workshop situation that will occur. So thanks for your sharing. And people who may not find yourself in that state, often it's because of one of these reasons, commonly known barriers like I'm bored, I feel worried or anxious, I'm angry about something or someone, I feel sad, I'm very, very depressed, not going to do me any good. There's very painful or very strong discomfort in my body. Actually, the point is this: actually, all of these barriers could really be addressed by hypnosis and right guided imagery. Often, the active ingredient or the active suggestion is this: that put your thought aside. If you recall what I said, put your thought on that discomfort or pain aside for a moment and refocus on that body. Right? You heard me say that, right? Actually, that putting aside and putting away and refocusing, the refocusing experience is really the single-minded focus. And you keep doing that, refocusing, the thought distracts you, refocusing, thought distracts you, refocusing. And you can train your mind to do that over and over again and quickly again, you find out you can do it for yourself. You don't need a therapist. That's the beauty of it. No side effects, safe. Anyone feel any side effects besides sleepiness? I know it's daytime, so you can say daytime sleepiness is a side effect, but that's different from hypnotic daytime sleepiness, right? Right. So these are really it, and that is my last slide. Really, I think I have no other slide. So to conclude, late life uh, sleep is different from earlier life sleep. Late life insomnia, while having many similarities, right, does have its peculiarities, and we realize that the older adults do not give much time to treatment. Do not may not want to entertain so much different treatment options. But what works and quite quickly and experientially is really hypnosis. And and at least CBT, the psychological aspect of treatment, that it has now become psychological treatment first line of defense before I talk about pharmaceuticals. Yeah, so I think that's about it. If nothing else, thank you very much. I'll see you next week. Bye bye.